to really cure atherosclerosis. Our problem is we're not looking for it.
Oh, I want to go so bad into that, but I'm going to ask you a quick question since we keep mentioning it, but we
Yeah.
haven't dug into it.
Yeah.
The lipid levels that we should make sure to include, and at what age? Is it basically at childhood, at 18? When do we start screening
Yes.
that way?
Well, I'll quote the sort of the pediatric guidelines. Now, I'm an adult cardiologist, but I'm aware of these guidelines. So pediatric guidelines to pick up kids with familial hypercholesterolemia, which is not uncommon. Every kid between 9 and 11, and again between 18 to 20, should have a cholesterol level checked.
Hmm.
Almost no one does. But you can pick it up at those early ages. And on top of that, for the kids that do have familial hypercholesterolemia, we have drugs that bring down cholesterol, stop plaque, reverse plaque, that are FDA approved for both
Hmm.
safety and tolerability down to 8 to 10 years of age. Now, I'm not saying we start putting all these kids on drugs, but for the select few that have significant high cholesterol that will
Hmm.
start accumulating in their blood vessels and ultimately translate to early premature heart attacks and strokes, it's fully appropriate. In fact,
Yeah.
one test which everybody needs, and probably about 1 or 2% of us have had it, is a really critical test. So listen up. It's called lipoprotein little a, or we call it LP little a. It's just a blood test. It's cheap. It's inexpensive. You check off the box. You have another blood work drawn or your cholesterol levels drawn or whatever. Check off the box. It is a really nasty form of cholesterol, right? It's
Hmm.
basically about 6 times more potent to form plaque than, quote, regular cholesterol. It is very sticky. It likes to form those plaques. It is very clotty. It really promotes the formation of blood clots in the blood vessels, and it's very inflammatory. It really inflames the lining of the vessel. It is not picked up on a standard cholesterol test, so you
Hmm.
have to order LP little a, and it's 100% genetic. 80% will be normal. Yahoo, eat right, exercise. That's great. Good for you, good for your siblings, good for your kids. 20% of us will have it, and your cholesterol levels can be absolutely perfect. We now, as a member and fellow and served on the board of the National Lipid Association, and this is what we recommend in Europe as well, the National Lipid Association says everybody once in their life gets an LP little a. If it's normal, it's normal. Eat right, exercise, we're great. Don't worry about it. But we'll pick up the 20%, 1 out of 5, that have this LP little a. And there are things we can do about it. So get your lipids, your standard lipid profile, get your LP little a. I'd also, whenever I measure cholesterol, we measure something called apolipoprotein B. We call it
Hmm.
ApoB, just a blood test, cheap, simple, easy. It's just a much better, sharper scalpel to understand all the bad cholesterol. Oh, by
And
the
you
way.
told me something quite interesting because, in the world of longevity and getting lots of tests done for better or worse, some people are getting things like ApoA1, some
Yeah.
people are getting particle sizes. Say briefly your thoughts
Yeah.
there.
So we've
Yeah.
gone deep in the world of lipids and all that. In the past, we've gone deep into all kinds of kind of crazy, expensive, obscure ways of slicing and dicing cholesterol. Well, we can look at particles. We can look at particle sizes. We can measure ApoA, which is basically the form of proteins that coats the HDL, the good cholesterol, right? So that's
Hmm.
kind of a surrogate for HDL. ApoB is the protein that coats all the bad cholesterol, right? LDL is
Hmm.
one of those, but there's others too. So ApoB is really the lumper. It's going to detect all of the bad cholesterol. Most of it is probably LDL, but there are other forms. ApoB is just a better, sharper scalpel to pick that up. So as it turns out, particle number, particle size, ApoA, all that,
Hmm.
useless, non-helpful, non-actionable. In the past, we used your particle number, your ApoA, maybe ratios, ApoB to ApoA, vice versa, all those things, because we did not have cardiac CT. We
Hmm.
were trying to guess, do you have plaque or not? So we tried to use these biochemical numbers to guess whether you had plaque. But it was purely
Hmm.
a guessing game. In the 21st century, you get in the cardiac CT, we do the AI, it's black and white, it's zeros and ones, you have it, you don't have it. Then we determine what are the targets we need to hit in you.
Hmm.
ApoB, LP little a, GLP-1s. We have an incredible array of diverse, multimodal, multi-mechanism tools that attack plaque. But the first step is get a diagnosis, because there are people on statins and cholesterol drugs, unbeknownst to them, don't have plaque. If you do not have plaque, this is the cancer analogy. Guess what? If you do not have plaque, you will probably not benefit from colon cancer chemotherapy.
Hmm.
Wild guess.
That's actually a very, very both brilliant and controversial approach because lots of doctors are obviously starting folks on whatever therapies before we ever see an image.
Without knowing, do I have the disease? Right? I
Mhm.
learned as an intern, you did too, probably
Mhm.
when you're in medical school than I did. And I'll say it, it's blunt, but I mean, it's actually true. And it really, no meat, no treat. So in the world of cancer, right? We don't go, oh, you're a smoker. You got a nodule that looks suspicious on your chest x-ray. Let's get you off to chemotherapy.
Mhm.
You need tissue, right? We don't do anything unless we confirm you have the disease.
Now let's go there. So, say someone's gotten the imaging done
Mhm.
and there's some plaque going on. Tell us a little bit about the therapies we have, how much we can actually reverse